So if you walk into an emergency room, right, with your blood pressure just so dangerously high that the monitors are screaming, a doctor's first instinct to bring that number down to normal could actually kill you. Welcome to the deep dive.
It sounds completely backward, I know, but it is entirely true.
Today, we are looking at a stack of highly specialized, really cutting-edge medical notes compiled by Dr. Asifullah, and they summarize the brand new 2024 updates from the American College of Cardiology, the American Heart Association, and the European Society of Cardiology.
Right. These are basically the heavyweight institutions of cardiovascular medicine, and the topic we're exploring today is hypertensive emergencies and severe blood pressure elevation.
Exactly. And the mission for you listening today is to decode the incredibly complex and honestly kind of shocking logic behind how modern medicine actually treats a blood pressure crisis.
Because it really is a complete paradigm shift. I mean, if you ask anyone on the street what to do when blood pressure spikes to, say, 180 over 120, the answer seems obvious, right? Lower it.
Yeah, just bring it back to 120 over 80 as fast as possible.
Exactly. But these new guidelines reveal that rapidly normalizing those numbers might actually be the most dangerous intervention a doctor could make.
Which is wild. The entire philosophy of cardiovascular care has evolved here.
Yeah.
We're no longer treating the numbers on a screen, right? We're treating the biological reality of the organs themselves.
We are. And to really understand that, we have to look at how the medical vocabulary itself has changed. The American Heart Association has effectively banned the term hypertensive urgency.
Yeah, that stuck out to me immediately in the notes. I mean, the word urgency just sounds like a call to action. It implies there's a fire that needs to be put out right now.
And that implication was actually causing harm. In the past, if a patient showed up with a blood pressure of 180 over 120, but they felt entirely fine, it was labeled a hypertensive agency.
Right.
And so doctors felt compelled to act on that word. They'd often administer aggressive, fast-acting medications just to force the pressure down.
But the 2024 guidelines basically tell doctors, hey, stop using that term. The new approved phrase is asymptomatic, markedly elevated BP, which honestly sounds intentionally boring.
It is. It's deliberately clinical to prevent panic. The guidelines draw a very hard line between two distinct scenarios. On one side, you have a true hypertensive emergency.
Okay, and what defines that?
Well, this requires a blood pressure of usually 180 over 120 or higher, plus active acute target organ damage.
So the high pressure is physically destroying tissue in real time. Like the notes list examples like a stroke, acute kidney injury, pulmonary edema, or an aortic dissection.
Right. In those specific scenarios, the patient is going straight to the ICU for intravenous, highly titratable drugs. But on the other side of the line, you have this asymptomatic, markedly elevated BP.
Where the monitor shows the exact same terrifying numbers, right? 180 over 120, but there's no acute organ injury.
Exactly. No organ damage, no emergency. That usually just requires oral therapy, maybe medication adjustments, and importantly, no hospitalization.
Okay, I have to step in here and push back on this a bit, because I imagine anyone listening is feeling the exact same sense of anxiety I am right now.
Oh, sure. It's a huge number.
Yeah. If a nurse takes my blood pressure and the cuff reads 180 over 120, how does a doctor look at that number and just not intervene immediately? I mean, even if my organs are fine in that exact moment, isn't that number itself a ticking time bomb?
I totally get that. And frankly, it is a profound psychological hurdle for clinicians as well. But the golden rule of these new guidelines dictates that treatment decisions must be based on organ damage, period. Never on the blood pressure metric alone.
So we just tolerate those massive numbers.
We have to. And to understand why, we really need to look under the hood at the pathophysiology of chronic hypertension.
Right. This brings us to the concept of the autoregulation shift. And I'll be honest, reading this part of the notes, the biology feels almost like science fiction.
It's incredible, really. You can think of the body as this highly advanced plumbing network. Normally, your vital organs, the brain, the kidneys, the heart, they auto-regulate their own blood flow.
So they control their own pressure.
Yeah, precisely. If you stand up too quickly and your overall blood pressure drops, the vessels in your brain instantly dilate to pull in more blood so you don't pass out. And if you exercise and pressure rises, they constrict.
They're doing this plumbing math on the fly to ensure constant, even perfusion.
Exactly. But chronic hypertension throws a massive wrench in that math. If someone walks around with high blood pressure for years, their body stops fighting it and instead adapts to it.
And the notes describe this as the cerebral autoregulation curve, literally shifting rightward.
Yes, the baseline physically moves. The smooth muscle in the blood vessels remodels itself to withstand that constant pounding. And as a result, the brain and the kidneys literally become addicted to and dependent on higher perfusion pressures.
Just to receive normal blood flow.
Right, just to function normally.
Let me try an analogy here to see if I really have this right. It's like driving a car at 100 miles per hour on the highway every single day for years.
Okay, I like where this is going.
Eventually, the engine tunes itself to only operate efficiently at that crazy speed, 100 miles per hour. So if you suddenly slam the brakes and drop to 20 miles per hour, which is supposed to be a normal, safe speed, the engine just stalls and the car crashes.
That captures the mechanism perfectly. The sudden drop to a normal pressure is the crash. If a patient is biologically adapted to 180 over 120 and a doctor rapidly drops them to 120 over 80, those heavily remodeled, tightened blood vessels just cannot relax fast enough.
I can't let the blood through at the lower pressure.
Exactly. So slamming the brakes actually starves the organs. You cause tissue ischemia.
Wow. So the notes point out that rapid overcorrection drops the pressure so fast it leads directly to cerebral infarction, which is a stroke, or renal hypoperfusion, which is basically shutting down the kidneys.
Right.
The doctor accidentally causes the exact organ damage they were trying to prevent in the first place.
It is a devastating iatrogenic injury, meaning it was caused by the medical treatment itself. Now, we should probably balance this by explaining what happens if the pressure spikes beyond even what the adapted vessels can handle.
Because a sudden uncontrolled rise does cause catastrophic damage at the microscopic level.
Oh, absolutely.
The notes use some very dense terminology for this. They mention endothelial injury, fibrotic necrosis, and microvascular thrombosis. Can we maybe translate those for the listener, starting with endothelial injury?
Sure. So imagine the innermost lining of your blood vessels as a delicate layer of Teflon.
Okay.
Extreme pressure acts like an industrial pressure washer, basically scouring and tearing that Teflon layer away. That is endothelial injury.
Ouch. And fibrinoid necrosis. I mean, necrosis means death, right?
Yes, the vessel walls, stripped of their protective lining, literally start to die. The tissue breaks down and turns into this fibrous pinkish sludge. That structural collapse is fibrinoid necrosis.
Which leads directly to the third term, microvascular thrombosis. The body senses all this raw, damaged tissue and just panics.
Right. The body's clotting cascade goes into absolute overdrive. It tries to patch the torn, dying vessels by throwing microscopic blood clots at the walls.
But that ends up completely plugging the tiny capillaries, right?
Exactly. Blood flow stops entirely. The vessels also become extremely leaky, allowing fluid to seep into the lungs, which causes acute pulmonary edema, or into the brain, causing hypertensive encephalopathy.
So it's a total systemic failure. The damage from a severe spike is catastrophic, but as we said, the damage from slamming the brakes to fix it is equally catastrophic, which introduces the general rule of hypertensive emergencies, the controlled descent.
Yes. The treatment target for most emergencies is incredibly conservative. The guidelines mandate reducing the mean arterial pressure by only 20 to 25% in the first hour.
Just 20%. I mean, that feels like doing almost nothing at all.
It really is an exercise in restraint. Over the next 2 to 6 hours, the goal is to lower the blood pressure to approximately 160 over 100 or 110.
Which is still dangerously high by any normal standard.
It is, but it's safe enough to stop the acute damage while keeping those adapted organs perfused. Only over the next 24 to 48 hours do clinicians attempt gradual normalization. You never attempt immediate normalization.
Okay, so that is the golden rule, the 20% glide path. But here is where the notes get really intense. Because in medicine, there are always rule breakers.
Oh, definitely.
What happens when a slow descent means the patient won't survive the hour? We have to talk about the exceptions, where doctors abandon the glide path and deliberately slam on the brakes.
These exceptions flip the entire protocol upside down. And we should probably start with aortic dissection.
Right. This is a tear in the inner layer of the aorta, the massive vessel carrying blood away from the heart.
Picture the wall of the aorta peeling apart like wet wallpaper. Every single time the heart beats, it drives a wedge of highly pressurized blood into that tear, ripping it further down the chest and abdomen.
Wow.
Yeah, you do not have hours to fix this, you have minutes.
The guidelines here are just terrifyingly aggressive. The target is to drop the systolic blood pressure to less than 120, and the heart rate to less than 60 beats per minute within a blistering 20 minutes.
It's a total medical freefall. But there is a vital pharmacological sequence that must be followed here. The preferred therapy utilizes an intravenous beta blocker, usually often paired with a vasodilator like nicardipine.
Now, I noticed a massive warning in Dr. Asifula's notes regarding this exact combination. The guidelines state you absolutely must administer the beta blocker before you give the vasodilator.
Yes.
Why does the order of the drugs dictate life or death? I mean, if the aorta is tearing from high pressure, shouldn't you just open the blood vessels as fast as possible?
It comes down to the physics of fluid dynamics, specifically something called shear stress, or dP/dt. That's the change in pressure over time.
The actual physical force of the blood hammering against the tear.
Exactly. If a doctor administers a vasodilator first, the blood vessels instantly open up and the pressure drops. But the body's baroreceptors sense this sudden drop and interpret it as a massive hemorrhage.
Like the body thinks it's bleeding out.
Right. So to keep the patient alive, the brain triggers a reflexive tachycardia. The heart rate spikes violently to compensate.
Oh, I see. So instead of 80 beats per minute, the heart starts pounding at like 130 beats per minute.
And that hyperactive pounding heart slams blood against the fragile, torn wall of the aorta with incredible velocity. This sheer stress increases massively, and you will literally rip the aorta wide open.
That is horrific.
So you must block the heart rate first. You administer the beta blocker to slow the engine down, and only then do you open the pipes with the vasodilator.
Block the heart rate, then open the pipes. That makes perfect biological sense. Okay, so sheer stress makes us slam the brakes. But what if we flip the scenario? What if the problem isn't a tearing pipe, but a completely blocked one?
Ah, yes.
That brings us to exception number 2, acute ischemic stroke.
This scenario demands probably the most counterintuitive restraint in all of emergency medicine. If a patient is suffering an acute ischemic stroke, meaning a blood clot is starving the brain of oxygen and they are not candidates for clot-busting drugs,
Yeah.
the guidelines dictate that you do not touch their blood pressure unless it exceeds 220 over 120.
Wait, hold on. I need to process this. You are saying a physician is supposed to stand at the foot of the bed, watch the monitor climb to 215 over 115, and put their hands in their pockets, doing absolutely nothing.
It requires immense discipline, I know, but there is a brilliant survival mechanism at play here. Because the brain is starving for oxygen behind that clot, the body deliberately drives the blood pressure up to astronomical levels.
Why?
It is trying to force collateral blood flow around the blockage to save the dying brain tissue, the area we call the penumbra.
So the high pressure isn't a symptom of the stroke, it's the body's desperate attempt to cure it.
Exactly. If a doctor administers a drug to lower that pressure, they remove the only force keeping that brain tissue alive. The stroke worsens instantly. Even if the pressure exceeds 220, the guidelines only permit lowering it by about 15% in the first 24 hours. Let it ride.
The only caveat here is if the patient is receiving thrombolysis, right? Clot-busting drugs.
Right. In that case, the targets shift. Thrombolytics carry a high risk of causing a hemorrhagic conversion where the ischemic stroke turns into a bleeding stroke.
Which is a nightmare.
Total nightmare. To prevent that, the pressure must be kept below 185 over 110 before administering the drug and below 180 over 105 afterward. It is a razor-thin tightrope between bleeding and starving the brain.
Incredible. Which brings us to a scenario where the source of the high pressure isn't a clot or a chronic condition, but an entirely new organ.
Yeah.
Exception number 3, pregnancy and eclampsia.
Right, where severe hypertension leads to seizures.
The targets here are strict. A systolic below 160 and a diastolic below 105 to 110. And the go-to drugs are IV levolol or hydralazine alongside magnesium sulfate to prevent the seizures.
But the notes make a fascinating distinction here. The definitive medical cure for eclampsia isn't actually a blood pressure drug.
Right. The drugs merely buy time. The definitive treatment is the delivery of the fetus and the placenta.
Exactly. The placenta itself releases factors that drive extreme systemic endothelial dysfunction. Until that source is removed, the medical team is really just bailing water out of a sinking boat.
So, to hit all these incredibly specific narrow windows, we've been talking about dropping the pressure in 20 minutes for a dissection or keeping it perfectly elevated for a stroke. Doctors clearly need the right tools.
They do.
This brings us to the pharmacy toolkit, the precision weapons of the ICU.
The 2024 updates provide a very clear hierarchy of which pharmacological weapons to deploy, based entirely on their mechanisms of action.
Let's start with the champions of the guidelines, calcium channel blockers, specifically the dihydropyridines like nicardipine and clovidipine. How do these actually work on the plumbing?
Well, we have to look at the muscle fibers lining the blood vessels. For a muscle to contract and tighten the vessel, calcium needs to enter the muscle cells. These drugs literally block those calcium channels. Without calcium, the smooth muscle cannot contract. It relaxes, the vessels dilate, and the pressure drops smoothly.
The notes highlight nicardipine for its excellent cerebral blood flow profile, making it a top choice for neurological emergencies. But clovidipine sounds even more advanced. It is labeled an ultra-short-acting drug.
Clovidipine really is an engineering marvel for the ICU. Because of its rapid onset and incredibly short half-life, it allows for minute-to-minute titration.
So super controllable.
Very. If the pressure drops slightly too low, the nurse just turns down the IV drip and the drug is cleared from the bloodstream in minutes.
There's a really specific clinical pearl in the notes here, though. Clovidipine is formulated in a lipid emulsion. Because of how it's manufactured, you cannot give it to patients with an allergy to soybeans or eggs.
Right. Those are the hidden details that prevent catastrophic allergic reactions in an already critical patient.
Let's move to the beta blockers. We established that esmolol is used for aortic dissections because of its 9-minute half-life. But labetalol shows up everywhere in these notes for stroke, encephalopathy, and pregnancy. What makes it so versatile?
Labetalol is unique because it is a dual-action drug. It blocks both alpha-1 and beta receptors.
How does blocking those specific receptors translate to the patient's actual blood pressure?
Well, alpha receptors are basically the switches that tell blood vessels to constrict. Beta receptors are the switches that tell the heart to beat faster and harder.
Oh, I see.
By blocking the alpha receptors, labetalol relaxes the pipes. Simultaneously, by blocking the beta receptors, it slows the heart rate.
So it prevents that reflexive tachycardia we talked about earlier with the sheer stress.
Exactly. It provides a highly predictable, smooth reduction in pressure. However, blocking beta receptors can be dangerous in certain populations.
Right.
You have to avoid labetalol in patients with severe bradycardia, a very slow heart rate, or acute decompensated heart failure, because a weak heart just cannot afford to be slowed down further.
That makes sense. The notes also say it is contraindicated in asthma, as beta blockade can trigger airway constriction.
Yep, you definitely want to avoid that.
Now we arrive at what I'm calling the fallen giant. Looking through the historical context of these notes, sodium nitroprusside used to be the ultimate weapon. It is an incredibly potent arterial and venous dilator. It just opens everything up.
It did. It was the gold standard for decades due to its raw potency.
But the 2024 guidelines are actively pushing it out of favor. Why?
Well, nitroprusside comes with a dark side rooted in its chemical structure. The molecule itself actually contains 5 cyanide groups.
Wait, literal cyanide,
Yeah.
as in the poison.
Yes. When the body breaks down the drug, it releases nitric oxide to dilate the vessels, which is great, but it also releases cyanide ions.
Good grief.
The liver tries to convert this into thiocyanate to be excreted by the kidneys, but with prolonged use, or if the patient's kidneys are failing, which is super common in a hypertensive crisis, the thiocyanate accumulates. It crosses into the brain and causes severe toxicity and altered mental status.
That is genuinely terrifying. The notes also mention it increases intracranial pressure, making it terrible for strokes. And it causes something called coronary steal, which sounds like a heist movie.
The mechanism operates very much like a heist, actually. Imagine a heart with some healthy blood vessels and some diseased, narrowed vessels.
Okay.
The diseased vessels are already dilated as wide as possible just to get a tiny trickle of blood to the heart muscle.
They're completely maxed out.
Right. When you administer nitroprusside, it forces all the blood vessels to dilate. The healthy vessels open up into massive new channels, creating a path of least resistance.
Oh, man. So blood just avoids the diseased ones.
Exactly. Blood flow is physically stolen away from the diseased stenotic vessels and diverted to the healthy ones, starving the already damaged heart muscle and worsening a heart attack.
Wow. Because of the cyanide risk, the brain swelling, and the coronary steal, the guidelines have obviously moved on to safer alternatives like nicardipine or clofidipine. It shows just how precise the matching of drug to condition has become.
It really does.
Like, for example, the notes specify using intravenous nitroglycerin for acute pulmonary edema or acute coronary syndrome because it specifically lowers the filling pressures of the heart.
Right. It reduces the workload on a struggling heart.
Before we wrap up, we should touch on one final, somewhat bizarre condition detailed in the notes, PRES, posterior reversible encephalopathy syndrome.
Ah, PRES. It is a classic visible manifestation of a hypertensive emergency. Remember the autoregulation shift we discussed?
Yeah, the body adapting to high pressure.
Well, PRES occurs when the blood pressure spikes so rapidly that it completely overwhelms the brain's autoregulatory safeguards.
The rightward shift fails, and the pressure just blows past the defenses.
Exactly. The blood-brain barrier breaks down. Fluid leaks out of the blood vessels and floods the brain tissue, primarily in the back of the brain, the parieto-occipital region.
Why specifically the back of the brain?
That area actually has fewer sympathetic nerves to clamp down the vessels, making it especially vulnerable to pressure blowouts.
And because it's in the back of the brain, the symptoms are incredibly specific. The notes list severe headache, altered mental status, visual disturbances, sometimes even cortical blindness and seizures.
It's scary, but the treatment brings us full circle. Careful, controlled blood pressure reduction, usually with nicardipine or labetalol, alongside seizure management.
We have covered a massive amount of ground today. Distilling this deep dive, the 2024 updates from the ACC, AHA, and ESC teach a profoundly humbling lesson about human physiology. In a hypertensive emergency, the blazing red numbers on the monitor are completely secondary to the biological reality of the organs.
The medical field has definitively shifted its mindset here. Clinicians are no longer acting as mechanics, simply fixing a pressure valve. They are operating as ecologists managing an adapted environment.
Doctors don't slam the brakes anymore, except for that tearing aorta. They guide the system down gently using highly specific pharmacological tools, completely respecting the fact that the body has rewired its own plumbing just to survive.
It is a perfect demonstration of how a deeper understanding of cellular mechanisms fundamentally alters bedside interventions. The precision isn't in fixing the number, the precision is in the pacing.
The precision is in the pacing. I love that. I want to leave you the listener with a lingering thought based on everything we have just uncovered.
Let's hear it.
We now know that chronic high blood pressure can physically rewire your brain, your kidneys, and your blood vessels, making them reliant on dangerous extremes just to function day to day. If the body is capable of remodeling its core infrastructure to survive that stress, what other unseen structural adaptations is your body quietly making right now in the background just to cope with the environment around you?
It really reframes how we view our own resilience, doesn't it?
It absolutely does.
Yeah.
Thanks for joining us on this deep dive. We'll see you next time.